Good morning, good afternoon, good evening. My name is Makayoto from Kenya. Very happy to be part of this meeting and glad to share with you our experience responding to the COVID-19 pandemic. So Kenya confirmed her first case on 13th of March this year. This was a young lady, 27-year-old, who had traveled from the US via London to Nairobi. And at the point of entry, she was asymptomatic. At this point, she was given information on the importance of self-isolation and also signs and symptoms to look out for. And sure enough, 5 days later, she reported to a health facility with signs and symptoms suggestive of corona. So here we are, 8 months down the line, and we have continued to progressively register additional cases. So as at 19th October, we had conducted slightly over 600,000 tests, out of which we confirmed 45,647 new confirmed cases. And so far, 71% of these confirmed cases have actually recovered, and 43% of them having undergone care in a health facility, isolation and health facility, while the rest, the 57, having undergone home-based care and isolation. Not everybody made it. Unfortunately, we lost 842 persons, translating to a case fatality rate of around 1.8%. This is slightly lower than the 2.8% that has been reported by WHO globally. So in the country, all the 47 counties have reported confirmed cases. A county is just the first subnational administrative unit. And if you look here, these are the demarcations, but most of our cases are centered around the capital, the metropolis. We also have a high attack rate in a city at the coast, in counties that host major points of entry, and that is just because of the strategy we adopted in testing of truck drivers who are crossing the region. And then we also have moderate attack rates in counties that host refugee camps. We have two, one in Garissa here, bordering Somalia, and one in Turkana, bordering South Sudan. Of note is that 93% of our cases are actually asymptomatic. So this graph just shows the trends of confirmed cases since the outbreak began. We had a gradual increase and a peak around mid-end July, then a gradual decrease. And in the last 2 weeks, we have actually seen another peak begin to gradually rise. The positivity rate from the tested samples seemed to follow the same pattern, peaking in July, a gradual decrease, and we're also seeing an increase. So what are the measures that the government has undertaken to control this pandemic? As a country, we have taken a whole government, whole society approach, brought all relevant stakeholders to the table, and we've also had a lot of support from His Excellency, the President. Pre-pandemic, he actually established a National Emergency Response Committee, which was chaired by the Cabinet Secretary Health, bringing together all relevant line ministries to give policy and strategic direction to respond to this pandemic. Then we have also activated emergency coordination structures, including the COVID-19 National Task Force, with all the relevant subcommittees, both at national and also similar structures at subnational level. Because of the economic crisis that was created by the pandemic, the government implemented some economic stimulus programs to cushion businesses and also individuals. As far as public health is concerned, we activated our Emergency Operations Center to strengthen coordination and also coordination of information. We strengthened surveillance at points of entry, facility, community level to be able to quickly detect any new cases, and also strengthen our capacity for case management, established isolation centers, and also increased capacity for critical care management. We established contact tracing, and also quarantine policies. And in addition to all this, expanded our testing capacity. Initially, we only had 2 laboratories in the capital, but even as we speak, we have 39 spread across the country. They are both private and public. Information to the public and messaging has been ongoing, continues to date, focusing on behavior change so that people adhere to the social public health social measures and encourage prevention. We have also undertaken some research, and the guidelines and policies that we offer, or rather have been released during this pandemic period, have actually been based on evidence. We also adopted the movement of restrictions as one key intervention. So we've had partial lockdowns, especially in areas that are hotspots. We closed our borders and suspended flights to also prevent additional importation of new cases, instituted dusk to dawn curfews to reduce movement of persons and also gathering of persons in entertainment spots, which could fuel the spread of the virus. So we also adopted some strategies to ensure there was physical distancing and social distancing. So we, very early in the pandemic, closed learning institutions. We have encouraged remote working, avoiding persons going to the office so that we avoid spread of infection within the office space, and also banned public events and gatherings like political rallies. We have had closed places of worship, and also have protocols on issues about, say, weddings, some of these social events like weddings and burials. So all this has not been smooth sailing. We've had some challenges. And one of the biggest challenges we had is that we were actually affected by the disruption of the global supply chain systems. So we've experienced shortage of PPE and also experienced shortages in diagnostic reagents. This being a novel virus, initially the demand was high, production was still low, and accessing some of these reagents and laboratory requirements has been a challenge. Then getting persons to change their social cultural behaviors and adopt to a new normal has also proven to be very difficult. One day we are shaking hands, tomorrow we cannot shake hands. One day we are attending barrels in hundreds. Now we are only maximum of 50 in a barrel. But I think with time, persons have actually accepted and are adapting to this new normal. We also had interruption of essential health services and also specialized care programs like immunization, cancer care, especially with the restriction of movement. Optimal cancer care is only found in some regional facilities, and because of the restriction of movement, affected persons' movement to these areas. The curfews, the dusk to dawn, might also have affected mothers who required maternity care during these hours. Then another big challenge was in contact tracing and implementation of quarantine measures. While persons only exposed, keeping them somewhere for 14 days proved to be very difficult. The pandemic came with an infodemic. Lots of myths and misconceptions flying around. Of course, through social media and with availability of internet, was very difficult to control. But I must say, there are some lessons that we have actually learned during this 8 months period. And one of them is that we need to sustain investment in preparedness if we hope for any seamless response to any public health emergency. Secondly, community engagement is key. And we need to involve the community during both preparedness and response if we expect them to cooperate in control or containment of any outbreak. Continuous risk communication is also very important at all times, because this reinforces desirable behavior change. And of course, that is what we want. So even during this period, as we keep communicating, we also get to address myths and misconceptions. Another major lesson that we've learned is the importance of strong multisectoral collaboration. This has proven to be key because it brings like-minded people to the table. We have one goal, but everybody sticks to their role. Everybody's playing what they do best. And I think with all this, the goal is always achieved. We've also had some best practices and successes during this pandemic. And one is the local manufacturing of personal protective equipment. There's a wise old saying about necessity being the mother of all inventions. We had to invent. The pandemic was in the country. We had shortages of PPE. We had to protect health workers so that they could take care of the persons infected with the virus. So we brought the local manufacturers on board, and they didn't let us down, gave them the standards of what we needed, and they delivered. They manufactured, locally manufactured gloves, masks, some coveralls, among other PPEs. We also established home-based isolation and care system, which prevented straining or overburdening the limited space available in health facilities. We increased ICUs and critical care management capacity, and also isolation beds at subnational level. And the beauty is that this infrastructure will continue to support implementation of UHC and even medical tourism beyond the pandemic. We have also contributed to technical assistance and support to neighboring countries. We provided surge capacity on request to Seychelles. So we deployed a multidisciplinary team of 50 health workers to go and support the COVID response in Seychelles. So what effect has COVID had on universal health coverage? I think one of the major effects is it has affected or rather reduced the proportion of the population that covered and that could access health services during this 8 months pandemic period. And I think this has been fueled by the stigma surrounding COVID. Kenyans have generally kept away from seeking healthcare services for fear of contracting COVID-19 in healthcare facilities. The controlled movement, especially in hotspots, has also denied Kenyans access to care when they actually needed it. And the pandemic has actually also exacerbated shortages of human resource because of the reallocation or reassignment of some of these human resources to responding to the outbreak. This has also been worsened by the fact that some health workers have also been infected and they needed to be isolated. The pandemic has also reduced access to quality services because of one, like the disruption of supply chains of general medicines generally, and other essential medicines and some equipment. So prices have gone up. There's stockouts of some of these medicines. There's lack of PPE. So it's actually leaves some question about the quality of services during this pandemic period. Then there's also been inappropriate use of medicines because of the myths on cure or treatment of COVID. People have hoarded, kept medicine just prepared in case they got it. There's also been a lot of misuse of some essential medicine that would have been useful to somebody else on treating upper respiratory tract infections. The pandemic has also, I think, strained an already under-resourced and ill-equipped system just before the pandemic. That was how the system was. By now overburdening it with an additional population of persons beyond what it can actually hold. Like for critical care, ICUs were not adequate before the pandemic, but now with the inadequate numbers, we have to add this new population to already an under-resourced system. Then a lot of diversion and of effort and focus, generally the healthcare system, and reallocation of funds both at national and subnational level. So all in all, we have our ability to monitor and evaluate activities of some of the programs we have been implementing even before the pandemic has actually been affected, because now we cannot put in place corrective action to improve access, or rather quality of some of these services that we offer. The pandemic has also had affected financial protection, which I think is a key pillar as far as UHC is concerned. It has had a negative economic impact because it has actually reduced country revenue collection. Taxes have some have gone down, we've been relieved of some, and also has increased expenditure on some of the new priorities that have come with the pandemic. This has impacted on the funding that had been allocated to strengthen rollout UHC. Financial protection to individuals through some of these private insurance companies has also burdened the common man, because the companies were very categorical from the beginning that they were not going to reimburse any medical expenditures related to COVID. And this has put a big burden to those who had taken some of these policies with the hope that when they get unwell, these insurance policies will actually cover them. So for us as a country, it leaves us this question, or rather lesson, that maybe we should plan to cover pandemics or public health emergencies and outbreaks as part of UHC scheme. The pandemic has also disrupted the planning and programming of UHC, because there were a series of meetings, consultative, participatory meetings with key stakeholders, community, to articulate issues on UHC. But because of the pandemic, this was not possible. It has also disrupted the plans by the human resource department and their processes on recruitment and also placement of additional healthcare workers. And I think all in all, it has actually delayed the UHC program milestones in the country. But I think for me, this has clearly shown, the pandemic has clearly shown the interdependence between UHC and health security. These things are inseparable, and we have to deliberately invest in both so that persons are not left vulnerable to any if anything were to happen. So for me, UHC and health security actually two sides of the same coin. So if you neglect one, then persons are already vulnerable on the side that you have neglected. So I think the pandemic generally has made it more urgent and more important for us to quickly upscale and implement UHC, and also to urgently strengthen health systems. So how do we move forward as a country? I think very important is that we'll continue to enhance and sustain the public health social measures that we have put in place, because COVID is here to stay. And as a people, we have to adapt. And I think prevention generally is better than cure. So we need to prevent the masses from getting infected with this virus. Then we continue to enhance surveillance, of course, through UHC, especially at community level, to be able to detect any changes, especially in the transmission or any new pathogens that come up, and also just to monitor the spread of this virus. So through this, we'll do through many strategies. Then again, through UHC, we enhance emergency preparedness and response. We cannot afford to relax because we never know. The situation remains fluid. Anything could happen, and we could even have an additional pandemic or epidemic to the ongoing COVID. So we need to continuously be prepared and ready to respond. Then again, through UHC, we continue to sustain the successes we've made and also carry forward this to response to future pandemics. And finally, incorporate the lessons we have learned even as we respond to this pandemic. And I think evaluations are done periodically, currently we are doing an interaction evaluation. So those lessons and that what we will also get after action and use this to incorporate and also strengthen even as we scale up UHC. So thank you very much for your time. Asanteni sana.